afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on sex differences among children, adolescents, and young adults for mental health service use before and during the COVID-19 pandemic. My name is Dr. Carl Cabasel, and I am the physician lead for health promotion, chronic disease, and injury prevention at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I'd like to cover a few housekeeping items. So first, you will notice that the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. That's capacity building, all one word, at oahpp.ca. And I'd like to state for the record that as the moderator of this session, I have no conflicts of interest, but I do have the great good fortune of working on an ongoing basis with one of our speakers, Dr. Jeff Anderson, from whom we will be hearing a little bit later. So it is now my pleasure to introduce the main speaker for today's presentation, Dr. John Moyne. Dr. Moyne is a postdoctoral fellow at the University of Toronto under the supervision of Dr. Jeff Anderson, who, as I mentioned, will be joining us a little bit later. Dr. Moyne obtained his PhD from the Institute of Health Policy, Management, and Evaluation in Health Systems Research, Program Evaluation, and Outcomes. He has a master's degree in public policy and administration from Toronto Metropolitan University and a BA honors degree in law and society and psychology from York University. His current research is focused on modeling both direct and indirect health impacts of COVID-19 on the healthcare system and vulnerable populations. John, welcome.
Thank you very much, Carl. And thank you everyone for being here today. And thanks again, PHO, for hosting these rounds. So without further ado, let's get started. I'd also like to declare that I have no conflicts of interest with regards to this presentation or the material contained within. I'd like to thank CIHR for funding this research and hundreds of other research studies around the country and for helping improve the lives of Canadians. My postdoctoral fellowship funding was provided by the University of Toronto Institute for Pandemics, an academic center dedicated to public health research and education on pandemic readiness, resilience, and recovery at the Dalla Lana School of Public Health. Additional funding was provided by the Better Access and Care for Complex Needs that was Ontario's response to the CIHR strategy for patient-oriented research for primary and integrated healthcare innovations. Other acknowledgements: the study contracted out ICS data and analytic services and used de-identified data from the ICS data repository, which is managed by ICS with support from its funders and partners, Canada Strategy for Patient-Oriented Research, the Ontario Support Unit, CIHR, and the Government of Ontario. The opinions, results, and conclusions reported are those of the authors. No endorsement by ICIS or any of its funders or partners is intended or should be inferred. Parts of this material are based on data and information compiled and provided by CIHI. However, the analysis, conclusions, opinions, and statements expressed herein are those of the author and not necessarily those of CIHI. So learning objectives for today: describe current trends related to mental health among children, adolescents, and young adults post-COVID-19. Discuss how these trends were affected by the COVID-19 pandemic with regards to sex and age and the implications for practice. Lastly, identify opportunities to improve mental health surveillance data, particularly with respect to critical indicators that may affect public health response. So let's go quickly through the background here. So novel virus emerges late fall, early 2020, winter 2020, quickly spreads around the world. COVID-19 is declared a pandemic by the World Health Organization on March 11, 2020. Lockdowns are instituted around the world, and here in Ontario were set in place on March 15th, 2020. The pandemic was an extremely turbulent time, especially for frontline healthcare workers. As a result, lockdowns were instituted to try and slow down the spread of the virus. Those lockdowns also extended to places of business. So early in the pandemic, we saw major cutting of hours or shifts, reduced salaries or wages, and major layoffs. And these layoffs disproportionately impacted smaller businesses, seen here as having the number of employees that they had. And it also disproportionately impacted different sectors. So hospitality, healthcare, social assistance, arts, entertainment, recreation, retail, among others, were hit particularly hard. Lockdowns affected schools, and many of you answered in the poll regarding that. So, for well over a year, we had total closures, partial reopenings, learning remotely, and then with Omicron, complete closures again. So it was a very turbulent time for children and youth. And in addition to school closures and hybrid learning, school grounds were closed down, organized activities for youth like community centers and organized activities, all of those were also shut down. And when students did go back, it was far from what they remembered, and classrooms were, far from normal. Other restrictions in addition to school closures, here we have the COVID-19 restriction index. We had canceling of public events, gym closures, restrictions on indoor dining and events, and restrictions on indoor and outdoor gatherings, which essentially affects almost every aspect apart from essential services. So remote learning is extremely challenging. We also know based on data that it's challenging for young adults and undergraduate students, much less for grade school and high school students. And at the same time, if parents were lucky enough to be able to work from home or still employed, they had to constantly juggle between multiple competing demands, dealing with their with work, with children, their children, and making sure that they stay on top of their education. So it's a very stressful time for everyone. I'm going to quickly run through a few frameworks just to set the stage for certain pre and post-COVID stressors. This is the despair framework. This came about before COVID-19. Despair, by definition, is the absence of hope. And what are some of the factors that led to that? Particularly was, economic stagnation and certain effects of that in terms of declining incomes, loss in job prospects, and other factors like that, which were particular risk factors for certain families and certain adults. And there's a trickle-down effect, which we can discuss later, between household income and how that trickles down to the children in that household. This is the social and economic impacts of COVID-19. Early during COVID, we had high case counts, deaths, job losses. During Omicron, we had a tremendous amount of cases. Deaths were lower, but proportionally, they still remained high. And although we had job recovery, the only point I want to make here is, as we think to the future, is that the recovery was eclipsed by inflation and rising costs, and that's top of mind for many families right now in terms of economic hardship. So those hardships continue for many families. We know that during COVID-19, based on several surveys, screen time increased for both boys and girls. Males tend to spend more time in terms of screen time for video games, whereas for females, it was more time spent on social media. There's been a term coined, compare and despair, and there are certain risk factors associated with excess social media use. Climate change is top of mind for young people. Climate change has huge implications for human society, and biodiversity can affect all aspects of human life. And if I may quote from the paper, many, referring to adolescents, feel the threat to their future, are overwhelmed by the scale of the problem, and are disillusioned by inadequate action of those in power. So that's pretty powerful. And there was a survey done in Ontario schools where they found that climate change was the #1 issue that worried young people. This is the Positive Mental Health Surveillance Indicator Framework from the Public Health Agency of Canada and their partners. Suffice to say that COVID-19 and all the measures taken to try and reduce the spread of the virus had impacts on people's positive mental health in respect of all these four levels at the individual, family, community, and societal level. So tangibly, what were those disruptions? We had changes in routines for young people, so having to physically distance from family, friends, places of worship, and other social communities, breaks in continuity of learning, switching from in-person to virtual learning, missing out on supplementary and early education opportunities, access limitations to personal workspace, technology, and connectivity issues at home for some families. There was breaks in continuity of healthcare, so missed well child and immunization visits, limited access to mental, speech, and occupational health services. There was missed significant life events, missing celebrations, family vacations, proms, graduation, dating, a lot of these really essential milestone life events. Loss in security and safety, so housing and security issues, housing and food insecurity is a big issue right now, particularly for some households. Increased exposure to domestic violence and online harms, particularly with those increased screen times, and threats of physical illness and uncertainty for the future. Some other studies on this topic. In England, over a quarter of children and young people reported sleep disruptions and high cases of isolation, feeling lonely and fearful of leaving home because of COVID-19 early in the pandemic. Another study found increases in depressive symptoms among youth. The socioeconomic impact on parents due to job losses, working from home, and social isolation also impacts children, particularly when there was job loss in the family, social isolation, which was measured via stress and cortisol levels collected via hair samples. So that was an interesting study. Another study in Ontario found that there was a major increase in use of mental health care services during the pandemic, particularly among adolescent females. Another study in Ontario found that there are indications that acute care services were up for eating disorders during the pandemic. So evidently, there has been measurable impacts of COVID-19 pandemic on the mental health of children, youth, and young adults, warranting greater focus in this area and expanding mental health promotion and surveillance efforts as we look to build back stronger. So now we're going to discuss advancing mental health surveillance and data. So according to a report from the Mental Health Commission of Canada, advancing mental health of Canadians will require 1, leadership and funding, 2, promotion and prevention, 3, access and services, and 4, data and research. And predominantly we'll be focusing on data and research for this presentation. Currently, there's no clear vision for mental health information as a whole. Organizations and research groups conduct health data analysis and mental health reporting, primarily in silos. However, there is no dedicated organization with a sole mandate to collect, analyze, and disseminate mental health information at the provincial level. OH did announce the Mental Health and Addiction Center of Excellence, but it's too early to kind of bridge some of these gaps, but it's too early to comment on their impact. So what is public health surveillance? It's defined by the World Health Organization as the continuous systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of public health practice. Such surveillance can, 1, serve as an early warning system for impending public health emergencies, 2, document the impact of an intervention or track progress towards specified goals, 3, monitor and clarify the epidemiology of health problems to allow priorities to be set and to inform public health policy and strategies. Data and surveillance and prevention, really at a high level, can help explore mental health across the lifespan to help us ask the right questions, better understand the cause of mental illness, and make mental illness, hopefully, some preventable. and also help improve detection, screening, and diagnoses, support people living with existing mental health conditions, and help drive improvements in health and social care, particularly, and it's a point that we may discuss during discussion, is that we need better benchmarks and agreed upon standard measures for tracking progress. And all of this falls within this continuum of care. So we need to ensure that there's data there to support positive mental health promotion, solutions to prevent mental health conditions and possible comorbidities, addressing current needs for treatment, root causes of relapse, and reoccurrence of mental health conditions, and using the right methods, indicators, and data to set priorities, inform progress, and improve these initiatives where possible. Now let's discuss some forms of data that can help us to achieve some of these aims. Administrative data is data that is collected at the provincial level, hospital admissions, discharge, physician billing, ambulatory care, drug databases, etc. Some examples are DAD, NACRS, OHIP, and ODB. Some advantages are huge, enormous volume of data, a tremendous opportunity for creative research, particularly through techniques such as linking data sets. Has the ability to provide nearly complete population coverage for all publicly funded services is another major advantage. Typically very high value for money because that infrastructure has already been put in place. Limited scope, but I do believe this can be improved as we go forward. And what I mean by that is you are restricted by the sorts of data and indicators that have been already collected to ask the questions that you're interested in or conduct the research that you're interested in. There is a lag time. In some cases, it could be well over a year. So there's tremendous lag times, but I do believe that this will improve as we move forward into the future. Another is that it does not include those who do not seek care or who seek care through private services or who may not be publicly insured at that time. So that's another drawback. Surveys, population-based, cross-sectional, identify a population, then administer data collection within the sample population. Some examples are CCHS and the OSDUHS, which for some that don't know is the Ontario Student Drug Use and Mental Health Study. Surveys are more flexible and can be designed to provide more comprehensive information compared to administrative data, able to target a wide spectrum of mental health and theorize determinants, and able to capture persons who have not reached the point of requiring mental health service, but may be at risk. Can be tailored to the objectives at hand and the necessary information or data required are not restricted to information captured by health administrative data. Typically good value for money. They are usually cross-sectional, so they suffer from the same inherent flaws as cross-sectional data and studies. Different surveys may use different questions and instruments to measure the same concepts or diagnoses. So sometimes this makes cross-survey comparisons, and sometimes different organizations have their own surveys. This makes comparisons difficult. High response rates are critical and declining in some cases. Sampling strategies, means of data collection continue to need refinement to keep samples representative. And I would say this is more a challenge than a drawback, but it is something to be mindful of. Proxy responses by parents may be an issue among surveys targeting persons below 18. So that's something to be mindful of. Longitudinal cohort studies, this falls more within the domain of research, namely concerned with answering questions around which risk factors or antecedent conditions are associated with subsequent illness. Advantage, especially useful at studying phenomena that occur over time, in addition to including delivery of services, evaluation of interventions, and other outcomes. Able to target a wide spectrum of mental health and determinants. Can be tailored to the objectives at hand and the necessary information or data required. If thought out well, they can address multiple objectives to maximize value for money and time. And contrary to popular belief, analysis need not happen at the end of the study, but can actually coincide with follow-up and those data collection windows as they are collected and appropriate to the study. Some drawbacks: expensive and resource intensive to plan and execute and ensure complete follow-up. The longer the study, the higher the risk of loss to follow-up, which is further compounded when dealing with younger populations and primary data collection. There may be privacy issues compounded with linking data, elapsed time, and increased time points on any given person. Other data sources, EMRs and EHRs, are a secure, integrated, and comprehensive view of a person's medical records based on information generated through a person's interactions with the healthcare system. Poplar is a good example of that. In theory, should be a rich resource for information on the delivery of care across multiple conditions and settings, including health outcomes. Currently, EMRs are more focused on acute care, infectious and chronic diseases, but I do believe this will improve in the future. So they suffer from some of the same limitations as health administrative data. One example is you need to access the care in order for your data to be captured. And it only highlights, typically they only highlight one care facility or network of providers. We need to work towards system-wide linkages, which is why I think Poplar is an interesting project, looking to bring together a network of EMR systems from a network of physicians. Case registries refers to a system of collected data covering all cases of a particular disease or other health conditions in a defined population. So most of you may be familiar with cancer or stroke registries, but there is little to none for mental health currently. Sentinel reporting systems involves a network of reporting sites, public health units, family health teams, labs, etc. Mental health applications are rare, but they do exist, such as in the UK. So, selection criteria for indicators, measures, and research. When we are looking to select these criteria, we should ensure that they are relevant. So information should be meaningful and relevant to the target users. They should be actionable. Information should be informative, influential, and able to support the change in public health practice and policy. They should be accurate. Information should reflect the best evidence of the day, scientifically sound, valid, reliable, sensitive to change, interpretable, and complete. Feasible, look to leverage available data, should be of sufficient quality to report on or institute new data collection that is cost-effective and of value. Ongoing, data is collected and collated regularly in a timely manner to allow for comparisons over time. So now I'd like to discuss our study on this topic, and I'd like to share that with you. It's the same title as the presentation. So I will skip here. Now I wanted to apply that selection criteria to our paper or research study, I should say. So it is relevant. Mental health is a critical issue among youth with serious consequences if ignored. Actionable, the study methodology that we have used is informative and can be used to support and inform change in public health practice and policy. It's accurate. The information that we provided reflects the best evidence of the day, is scientifically sound, valid, reliable, sensitive to change, and interpretable. This is quite a feasible project. It leveraged existing data assets, used very high quality data, is cost effective and of value. And this kind of work can be done in an ongoing basis. Data is collected and collated regularly, and this allows us for comparisons over time. So now let's discuss study objectives. The objectives of the study were to examine whether the rates of mental health visits had changed during the pandemic versus COVID-19 pre-pandemic patterns, and to identify possible variations by sex, provider type, and clinical diagnosis among children, adolescents, and young adults. This was a population-based repeat cross-sectional study, which is also a type of time series using existing health administrative data. So as we discussed here, we leveraged health administrative data to conduct this research study. It included all children 6 to 12 years of age, adolescents 13 to 17 years, and young adults 18 to 24 years living in Ontario, Canada, and eligible for provincial health insurance between March 2016 to November 2021. A baseline measure of mental health rates of use was obtained from the pre-pandemic period. So we fit a model, and I'll discuss that further, from March 2016 to February 2020 to have a baseline. And rates of use during the pandemic are based on utilization starting from March 2020. So that was the onset of the lockdowns and the pandemic till the end of November 2021. Data was provided to us in a quarterly format, which was 23 cross-sectional measures. Exclusion criteria were persons with missing IKN, birth date, sex, OHIP eligibility, or who were non-residents in the province, or who had died prior to index. As I discussed, the three cohorts were children 6 to 12, adolescents 13 to 17, and young adults 18 to 24. These were open cohorts, and we assessed time at risk for the outcomes of interest. So these were some of those health administrative databases that we discussed. RPDB was used to gauge sex, age, postal code, and date of birth. OHIP was for the billing records for outpatient visits to general practitioners, family physicians, and psychiatrists. NACRS, DAD, and OMERS were used to identify mental health-related emergency department visits and hospitalizations using ICD-9 and 10 codes. So these are study outcomes in terms of outpatient mental health visits, and working our way from the left to the right, you can see the column corresponding to each cohort and the X corresponding to the outcomes that were collected for those cohorts. So they were mood and anxiety disorders, other non-psychotic disorders, alcohol and substance abuse disorder, and social problems within the outpatient setting. In terms of ED and hospitalizations, we looked at substance-related and addictive disorders, anxiety disorders, assault-related injuries, deliberate self-harm, and eating disorders. In terms of analysis, we use a negative binomial regression with time and season as predictors, and we use this to model utilization trends before the pandemic. Residuals were modeled as autoregressive to deal with issues such as autocorrelation and correlated data. The fitted model was used to predict the expected rates of use for March 2020 to the end of November 2021. All outcomes were stratified by sex, provider type, and mental health diagnosis. So the entire study, we ended up including a total of 6 million youth between the ages of 6 to 24 years of age from Ontario, Canada. And that speaks to one of the major advantages of using health administrative data. So now let's look to the results, and I hope this is legible on your end. So before I discuss the findings, I just want you to see, working from the left to the right of this figure here, we have on the y-axis, we have rates per thousand, and these are actual visits. So the numbers correspond to actual rate of visits per thousand. The blue line is indicative of females, and red is for males. The dotted line is that trend line that we discussed. It is the model we created based on 4 years of data prior to COVID-19 to give a sense of what is a normal ebb and flow, or what is the normal rate of use for these services or outcomes. And the solid line is the actual rate of use. And another thing to pay attention to here is if you look at the columns, each one left to right corresponds to one of the cohorts, and that the dotted line going down vertically is indicative of the onset of the pandemic. So we saw higher than expected rates for outpatient mental health visits among adolescent and young female adults, and you could see that in the second and third column from the left. We saw little to no difference among males. Now, here we break it down into those individual conditions. What we had in the previous slide was the total number of visits. So here we're looking at it broken down for males, and you could see that there's little to nothing happening in terms of service use. But when we switch it to female cohorts, we see higher than expected rates among females, driven largely by mood and anxiety disorders, and that is the blue line. And the green line is other non-psychotic disorders, black line is social problems, and the red line is alcohol and substance use disorders. So not much was going on there. So we saw highest differences among young female adults, followed by adolescent females. Now we're going to look at ED visits and hospitalizations. They were down among males in all three age groups. ED visits and hospitalizations were down or non-significant among female children and young adult cohorts, so that's important to keep in mind. However, in the female adolescent populations, we did detect increases in mental health ED visits and ED visits requiring hospitalizations and mental health related hospitalizations. And that was despite it being lower in the other two age groups. And another thing I'll mention quickly is that the data for the ED and hospitalization events are rate per 100,000 because they are more rare than outpatient events. So now when we break down what was this higher difference in hospitalization and ED, let's look at deliberate self-harm. ED visits for deliberate self-harm were up 42.8%. This is relatively higher to pre-pandemic trends. In absolute figures, it was 258 versus 181 episodes of what we would have expected during this time based on our modeling per 100,000. And this occurred in the September-November 2021 quarter, which was the last quarter in our study. ED visits for deliberate self-harm requiring hospitalizations were also up 46%. And in absolute numbers, this is 110 versus 80 per 100,000 in the same time frame. Hospitalizations were up for deliberate self-harm, 102%. In absolute terms, this was 354 versus 175 per 100,000 in the same time frame. So deliberate self-harm was persistently higher in every quarter since the pandemic in all of these ED requiring hospitalizations and hospitalization indicators. And particularly with regards to ED requiring hospitalization and hospitalizations going up, it could be an indicator of greater severity. I would also add that I am only presenting the highest differences here, but there were many other points in time where rates were higher than what we would have expected. Assault-related injuries. ED visits for assault-related injuries requiring hospitalizations were up nearly 500%. Very small in absolute terms. We saw 2 versus 0.4 per 100,000, so it's good that it's not very high in absolute terms. Hospitalizations for assault-related injuries were up 272%. In absolute terms, we saw 3 versus 1 per 100,000. So we saw higher on average by quarter and over the course of the study in these two indicators. Now looking at eating disorders, ED visits for eating disorders were up 225%. In absolute terms, it meant that we saw 59 versus 18 per 100,000 in the quarter September-November 2021. ED visits requiring hospitalizations were up 221%. That's 27 versus 8 per 100,000 in the same quarter, and comparably in the March-May quarter as well. Hospitalizations for eating disorders were up 139%, or in absolute terms, 64 versus 26 episodes or visits per 100,000 in the March-May quarter of 2021. So we saw persistently higher rates in every quarter since the pandemic in these three areas of care. So some strengths and limitations. This was a large population-based study representative of the Ontario population. Well-established mental health quality indicators based on health administrative billing codes. Many have been validated and used in routine reporting and peer-reviewed studies. Strong methodological design and analysis over time. Some negatives is that studies with outcomes based on healthcare utilization, such as ours, may underestimate the true prevalence of these health outcomes due to non-seeking of care or the seeking of care in other medical establishments, such as private clinics. And if I may also add, is these findings are really the tip of the iceberg. They do not detect people who are at high risk. Did not account for characteristics beyond age and sex. This is something we're interested in the near future, and also the intersection of some risk factors or sociodemographic factors in seeing which particular groups these outcomes affected. I think that's important to pursue. And while results are generalizable to the population of Ontario, Canada, they may not be generalizable to other jurisdictions where COVID-19 cases, containment policies, boundaries, and population characteristics are different. So study conclusions. Over 20 months into the COVID-19 pandemic, we observed a substantial increase in the use of physician services for mental health diagnoses relative to pre-pandemic levels, and that this was seen predominantly among female adolescents and young adults. Increase in utilization was largely driven by outpatient services for mood, anxiety, and depressive disorders, and this was highest among young female adults, followed by female adolescents. We noted an increase in case and severity for eating disorders, deliberate self-harm, and assault-related injuries among adolescent females in EDs and hospitals. Our study raises concerns about growing mental health needs among female adolescents and young adults during the pandemic, especially in critical areas such as depression, anxiety, deliberate self-harm, eating disorders, and assault-related injury. Now, to tie it all together, mental health among youth is a growing issue compounded by COVID-19 and other factors. More emphasis is needed on monitoring mental health of children, youth, and younger adults, especially as we look to recover from the pandemic and build back stronger. We provided a brief outline as to the state of mental health surveillance in Ontario and the challenges they face. In support of these efforts, we need to ensure that the information being used are relevant, accurate, actionable, feasible, and ongoing. We shared one possible approach, which can be used to evaluate critical mental health indicators at the population level, and also possible interventions in the future. Over the course of the pandemic, we observed substantially higher use of physician services for mood and anxiety disorders among female adolescents and young adults. We noted an increase in cases and severity of eating disorders, deliberate self-harm, and assault-related injuries among adolescent females in EDs and hospitals. Our study raises concerns about sustained growth in mental health service needs among female adolescents and young adults during the pandemic. And in closing, with major challenges and uncertainty around climate change, the economy, and cost of living, automation, technology, social media, misinformation, geopolitics, COVID-19 and other zoonotic diseases, and many others, it is critical that we have robust and responsive surveillance systems, especially around mental health indicators for children, youth, and young adults as we venture forward in meeting these challenges. Thank you.
We're now ready to move on to the question and answer section of this event to address some of the questions from our audience. Now, joining us for that Q&A is Dr. Jeff Anderson, who is a professor in the Institute of Health Policy Management and Evaluation of the Dalla Lana School of Public Health at the University of Toronto. His research is focused on measuring health needs and outcomes in high needs and vulnerable populations to better understand health inequities and to inform appropriate policy responses. And his research has been funded by provincial, national, and international funding agencies. He has extensive experience in international comparisons of health policy and outcomes. Welcome, Dr. Anderson. We'll just get you to
Thank you.
unmute. There
Great to
you
be
go.
here.
So yeah, and before we dive into the questions and answers, Jeff, did you have any sort of preliminary comments?
I'd just like to start. First, I'd like to thank John for the work and the people at ICS and ICS and DAS for supporting this work. And, you know, I think it does show that in Ontario, we have the ability to track these things. And I guess the other thing I would say is that in terms of restrictions, Ontario had probably in the world amongst the most strict restrictions on school attendance in the world. Right. And that was a decision that was made. It's a complicated decision. I'm not saying it was an easy decision to make one way or the other. But I think what you're seeing, and as your original poll stated, most people thought that, you know, school closures were stressful for kids. And to be honest, I think we had more school closures in Ontario than virtually any other jurisdiction. I think I heard, this may or may not be true, in France, they never closed schools during the whole pandemic. So, you know, we made some decisions that we probably need to look into.
Okay, thanks, Jeff. We have a lot of questions in the Q&A pod. And before we get into them, I just want to remind attendees to please continue to enter your questions into that Q&A pod if you've not already had an opportunity to do so. Let's start right at the top. One participant says, thank you for the talk. Any idea why substance use rates did not increase in the cohort as overall? My understanding is that substance use increased in adults during the pandemic. John, do you want to take that one?
Sure, I could speak to that. Certainly, there may have been increases, particularly with regards to opioids and even alcohol and certain other substances early in the pandemic among the adult population. But a lot of those figures tend to look at the entire population as a whole. I think once you look at the youth, particular population in the youth, you'll see that overall, at least as our indicators would suggest, and you know, when we're on the service use kind of side, so meaning that typically people who are willing to seek help, people who may have more serious substance abuse issues would seek help. That's what we would detect. But I don't think the issue was as bad among youth. There are some studies indicating that teenagers, there was less peer pressure, for example, because they were not physically in school. So some of those indicators may have gone down. And the last thing I'll say about that is we did detect a slight increase in alcohol and substance abuse among young male adults in our study. But based on our other findings was fairly minor, which is why we did not discuss that with regards to the presentation today. I'll pass it along to Jeff if he has anything to add to that. Yeah. Thank you for your question.
Thanks for the question. And I think John has kind of nailed it. I think this is one of the key things about this work is the gender and gender roles. Like these are conditions, eating disorders are as you probably realize more common in females. And, you know, as John pointed out, opioid and drug abuse and alcohol abuse are more common in males. So I think one of the stunning things about this to me is that the gender specificity of these effects, right? This is the first time in 30 years of research I've seen anything like this in terms of the impacts being on one gender. And I keep using the word gender because I think it's based on the role rather than the biology, to be honest, right? That young women are in a different set of environments than young boys. And the impacts of the pandemic, I think, played out particularly in females. And, you know, the role of the internet and the loss of social interactions, I think, are really, you know, really interesting points in this one.
Okay, thank you, Jeff and John. Next question, has the paper been published in part or in full?
The answer is no, we're trying to get it published. The publication process, as most people would know, is slow. So we're hoping to get it into a good journal. And one of the reasons we wanted to present it at rounds is that we thought you folks needed to hear this before it gets published. We think the results are sound, so we don't think there's no fundamental flaws in this. It's just, I think it's really important to get this out to the public as soon as possible. And you're an important part of that public.
Indeed. Next question. Was there an EDI lens, i.e. looking at race, socioeconomic status, etc.?
I'll speak to that quickly. For this particular research, we did not look at it from an EDI lens, but it's very good that you mentioned that, because we're very interested in building on this work with regards to looking at some of those factors and certain high risk or vulnerable groups. Jeff, did you want to add anything to that?
Yeah, I think, as you probably know, collecting race data is a complicated issue in Ontario, and it's one under debate. But we are hoping to use data from the census, the most recent census. So we won't be able to talk about the race of individuals or their economic circumstances, but we will be able to talk about neighborhoods. And I honestly think the idea of focusing this on neighborhoods at risk is going to be interesting. I think that the findings are still out on this. I'm not sure if this is a disease of high income people, right? Or is it like most other conditions that we're actually going to find the biggest impact in lower socioeconomic and marginalized populations? It'd be interesting to hear what lots of people in the audience are frontline providers. It'd be great to hear from them who they think was going to be most affected by these things.
Okay, very good. Next question. What are your recommendations for a robust surveillance system for mental health?
Tricky question, but it's a complex question, and really, to give you a quick answer, there's a lot of organizations and researchers doing really amazing work out there, and they're providing a lot of value. I think what we really need is greater leadership and more opportunities such as this one, where we cross-collaborate between organizations. So here we are, a small group of researchers in Jeff's team, and here we have PHO, a huge government organization, and that we can kind of work together to continue to build capacity in terms of improving surveillance, informing our public health officials on what is going on today, what do we anticipate is going to be happening in the near future, and how can we go about best addressing those challenges to really, ultimately we're all in it to try and improve the lives and quality of life of Ontarians and Canadians.
Just to pick up on what John was saying, I think we'd like to hear from you what you would need. I mean, that's where, research is research, but research in data and action is where we want to go. And part of this dialogue that we're having with Carl and other people at PHO is like, what information could support PHO? I know you have mental health as a priority. As soon as we came out of the pandemic, we sort of went to Public Health Ontario and asked what their priorities were. And mental health was on top of the list, to be honest. And so I know you folks are interested in it. The question is, of those options for collecting data and using data, which ones are going to be most relevant to you, and how can we work with you to make sure those data are in place and provided at the right level, like at the public health unit level? So I think this is part of a dialogue. We really want to hear from you about what you would recommend. That John did a great job of outlining the opportunities. We're kind of based on using administrative data, but there's other opportunities. The administrative data is good, but it has limitations. So again, I think the point here is we'd like to hear from you and make this a collaborative effort.
Excellent. We have a lot of questions. Let's go to the next one. A survey was referenced that mentioned climate change was the #1 worry for students. Can you let us know which surveys this was?
Yeah, absolutely. I had mentioned it during the presentation. This was the Ontario, and let me not mess it up. I want to make sure I give you the right answer, because I was also interested when I found it. It was the Ontario Student Drug Use and Mental Health Survey. And yeah, this was the 2019 or 2020, the latest version of the survey.
Okay, thank you for that. Listen, I know both of you have talked about getting feedback from our participants, and it sounds like you're very open to that two-way dialogue. Would it be okay if we shared your email addresses with the group and put it in the chat?
Absolutely.
Okay, good. Yeah. So I know our time is running out, but I know that there'll be a lot of positive and helpful feedback coming from our audience. Let's move to the next question. Sort of answered before, when will the results and methods for this analysis be available?
I think we're happy to share the results. To be honest, we have to give credit to ICES for this. We took the measures that they've developed and used in their mental health reports for years. We didn't create any of these measures. We took them off the shelf. ICES made this survey happen. I think we heard from ICES that they've actually shared some mental health data with the public health units recently. So my suggestion is if you want to understand the methods, it would be great if you could. We are vessels to bring you methods that have been developed and tested by ICES. So happy to share.
Yeah, thank you, Jeff. What I would add to that is, so we have two papers in peer review. So I cannot share them currently, but if feel free to email me, as Jeff said, we're certainly not the only ones to use this methodology. I can share with you two papers off the top of my mind, which has used similar data, looking at different outcomes, of course, but the methodology, everything, the health administrative data are all very, very similar. Thank you.
Okay, excellent. And yeah, the email addresses should be popping up in the chat. But as you can imagine, the formula is pretty simple, john.moyne@utoronto.ca. But with Jeff, it's a little tricky. It's Jeff, not Jeffrey, Jeff, GEOFF .anderson@utoronto.ca. All right, thanks again. Next question. Do we have a sense of the proportion of children/youth who are seeking care privately rather than through publicly funded programs, and how might they differ?
That's a tough question, and John mentioned it at the beginning. We're only looking at people that use the public resources that are paid for by the provincial government. So we're using OHIP billings primarily and hospital stuff. So we have a sort of a blind spot there. I would suggest to you folks that one of the other ways we could tap into this is what we're learning about mental health services done through schools and through, my understanding is that public health units are actually involved in some community level mental health service delivery. So I think I kind of turn this one around to you folks. So where else do you think we could get data on the private sector and stuff that's outside of the government billing?
Okay, just a quick bit of housekeeping. We have a lot of questions in the chat. We want to get to as many as we can. We're almost at 1 o'clock. With the indulgence of the audience, we'll go just beyond. We'll go to 1:05 so we can answer some more questions. Thank you. All right, next. Are there any plans to repeat the surveillance on a regular schedule? Did you do a breakdown of the outcomes by public health unit area? Or if not, would that be possible?
So the answer to that is that it is possible. The way we access data, we couldn't provide you with public health unit level data because we have restrictions on what data we can present to you, but there's absolutely no reason that I can think of that you couldn't go to ICS and ask for an ARC that used these methods to get you data updated at the public health unit level. And if that was the only thing that occurred from today's event, I'd be delighted. You know, if we could sort of transfer this. If you folks are interested, there's a path to get it done. And the fact that you sound like you're interested is the victory that I think John and I have had today. Like, we're researchers. We want this to be part of ongoing analysis, as John pointed out.
Okay. Why do you think the effects of the pandemic were more pronounced among females? Do you have any theories on that?
I think this is really the big question. And I haven't come across any papers that gave me the definitive answer. We have good plausible theories as to why that may have been. One that I alluded to was screen time increase for both boys and girls, or males and females. Sorry, using that interchangeably. But it seemed like, where was that additional screen time? And it seemed like for males, it tended to be more kind of activity-based screen time, such as video games and stuff like that. Whereas for females, it was more social media screen time. And as I alluded to, social media for some has been known to be a risk factor for certain mental health negative mental health outcomes. So that's one plausible theory. There are several, but in the interest of time, and I also want to give Jeff an opportunity to speak to that.
No, that's beyond my, I think John has alluded, I think there's lots of theories. Neither of us are psychiatrists or psychologists, but I think they're related to gender roles, right? It's just the role of that young women are faced, and as John pointed out, the difference in what an online experience for a boy is versus a young woman or a girl.
And if I may add one more thing, which was particularly interesting finding for myself, as Jeff said, we're not a psychiatrist by training, is that right now there's a huge issue with regards to food insecurity. And I was it was a connection that I never made, but there was some papers to suggest that despite it doesn't seem logical, but when there's food insecurity, it puts some at risk for eating disorders. So this may be also another plausible theory, but again, something we're very interested in, and I'm sure other researchers as well.
Okay, next question. It says, my question is about March and April of 2020 and the onset of the pandemic. We saw a significant drop in healthcare utilization, and CIHI showed a 52% drop in ER visits across Canada. Did you notice this pattern in your data?
The short answer is yes. We saw very similar patterns. Essentially, at the onset of the pandemic, not only containment measures, but also fear of contracting the virus certainly had an impact of seeking of care. Also, the health system needed a bit of time to adjust in terms of providing virtual care. So certainly, again, a short answer to your question is we saw very similar trends in our outcomes as well. Jeff, did you want to add anything to that?
No, I think that's correct. So there was a dip in EDs. I guess the one thing I would say is what I think John highlighted is the mental health impacts. We were finding them 20 months out. So it was last Christmas. But as I think if people can remember, the last December was not a great time in the pandemic, right? But I think the concerns are that those mental health impacts may be continuing. And that's the open question here, right? Is this going to get any better, or are we on a track that's kind of tipped a bunch of people into a distress that's going to echo for years and maybe have cross-generational impacts?
Okay, final question. Have you considered using the Ontario Marginalization Index to explore stratification by marginalization?
Thank you for that question and suggestion. Have you been at our meetings? Absolutely. It is actually something we're very much interested in and something that we're actively looking at right now.
Just to add to that, the beauty of this, I hate to say the beauty of this, is that we have a census that was conducted at the beginning of the pandemic. People may forget that, but we actually had a 2020 census. So most of the data we have in the OnMarg is from 2016. And I think we're going to wait a bit till we get the 2020 data, which will be much more specific to the time and place.
All right, fantastic questions, great discussion. Now, as we wrap up today's PHO rounds, I'd like to thank Dr. John Moyne and Dr. Jeff Anderson for presenting, and I'd like to also thank all of you who joined us today for this event. Now, you can expect to receive a brief and anonymous PHO rounds survey for today's session. Please try to complete this, but it will really help us to improve our programming if you would. So please think about doing that for us. Also, we'd like to remind you that the Ontario Public Health Convention will be held on March 27th and March 30th. So to register for the virtual convention, that's on the 27th, or the in-person workshops on the 30th, visit the website www.tophc.ca. We normally pronounce that as topic, tophc.ca. Finally, to access past PHO rounds presentations and to view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and then click on Presentations. Thank you all, and have a wonderful day.